All right, so good evening once again. I'm JK Emmanuel, CEO of JK Consult. So today we're going to talk about um, the chapter 3, which is the classification of mental illness. So in our previous lectures, we looked at the definition for mental health, definition for mental illness, differences between mental health and then mental illness. We looked at the factors that promote mental health, and we also looked at the factors that predisposes someone in getting mental illness. We also looked in our chapter 2, that's the second lectures. We looked at prevention of mental illness, the factors that differentiate normality from abnormality, and we also looked at the various way of managing your psychiatric patients. We looked at assessments in psychiatric health nursing. Now, today is lecture 3, and we're going to talk about the classification of mental illness. So, mental illness has been classified into different categories. So, we are going to look at all the classifications. So, we have here the functional psychosis. So we talk about the classification of mental illness. Then we have the functional psychosis. We'll talk about it. So under the functional psychosis, we have some basic mental illness that we'll be talking about under the functional psychosis. So we'll talk about the schizophrenia. We'll look at the causes, the incidents, and then the symptoms. We'll look at the prognosis, and then we also look at other psychotic disorders. Then we look at nursing interventions for schizophrenia. We look at the management for what? For schizophrenia. And then, so let's look at, so when we say mental illness, it has been classified into two main classes, basically two. Is that okay? Basically we have two. Basically, we have two classifications. So we have the psychosis, and then we have the neurosis. So either psychosis or a neurosis. So someone's mental condition may be either psychosis or neurosis. So let's look at the psychosis. So a mental disorder in which there is impairment in mental functioning such as thinking and feelings. So mostly the psychosis mental illness or the mental illness which are classified under psychosis, mostly it has to do with the impairment in the mental function, how the patient's mental functions. So these mental illness which are under the psychosis category, mostly they are more or less like the patient's brain, like biologically the brain is working, but then functionally the brain is not performing the function that it's supposed to perform. So, assuming we should take the brain and do some laboratory tests on such a person's brain, we wouldn't see any biological significance, maybe cell death or anything of that sort. The brain cells are intact, just that it is refusing to function as it's supposed to function, as a manifestation of the patient's behavior, feelings, emotions, thinking. Is that okay? So the condition can be grouped into either functional. So we have the functional psychosis. That's how we have the functional psychosis. Is that okay? So either a functional psychosis or the organic one. So for the functional psychosis, this is whereby the brain cells is believed to be what? To be intact. It's believed to be what? To be intact. But the person will manifest unaccepted with behavior. So like I said, psychosis, we have two subcategories, the functional psychosis and then the organic psychosis. But then the functional psychosis, that one, the brain is intact. Like I said, if you take the patient's brain and then view it, take it to the lab, there is no damage to the brain cell. Everything is intact. But then the person is behaving abnormally or is behaving or is manifesting unaccepted behaviors. So such mental illness and a functional psychosis is schizophrenia. So if you take a schizophrenic patient, if you examine the brain medically, you realize that everything is okay. The brain cells are intact. But then you realize that yes, so the patient is, manifesting some weird signs and symptoms or weird behaviors. Is that okay? Like bipolar, mania, and all of those, depression. But then the organic psychosis is the opposite of the functional psychosis. For that one, there is a pathological brain damage or brain cell damage, which is leading to the unacceptable behavior of the patient or of the client. So that's the main difference between the functional psychosis and then the organic psychosis. For the functional psychosis, the brain cells are intact. Yes, so the patient is exhibiting unaccepted behavior. But then the organic psychosis, the patient's brain cell is damaged. That is why the patient is exhibiting such manifestations or unaccepted behaviors. So, example of organic psychosis, we have the delirium tremors, we have the dementia. So the delirium tremors and then the dementia. So we will look at all these conditions. And we have the other category or other classification, which is the neurosis. Neurosis. For the neurosis, neurons, is that not it? Neurons, what they do is that they transmit signals, right? They transmit signals. They detect deviation and all of those. So neurosis, it is the manifestation of maladaptation of or to life stresses. So if there is some challenges that you are facing, if there is some challenges that someone is facing, you realize that all of a sudden the person will start manifesting some signs and symptoms to try to adjust or adapt to the stress at that moment. Is that okay? So for instance, we have anxiety. Anxiety is a neurosis because you see, if there is a life stressor, let's say examination, impromptu exam or impromptu quiz or an IA. If your lecturer is organizing an IA that you haven't read anything, you see how anxious you become. So you become anxious because you want to what? Try to, because you are not able to adapt to such examination stressor at that moment. So you be anxious. Is that okay? So this is neurosis and then psychosis. So you should know the patient may present with, or you get a question in a scenario form whereby the patient is presenting with signs and symptoms of anxiety, and we will learn anxiety disorder. And you'll be asked to classify as whether anxiety is a neurosis or a psychosis. So you should know. We have the others. Yesterday, I recall in a previous lectures, I mentioned that mental illness is the most abundant disease condition. Yes, it's a lot. So we have others. So we have the others. So initially the classification was done years ago. So these are the new ones that has been added. So we say, and then the others. So we said we have the psychosis, the neurosis. That's the main. But then apart from that, we have the others. So the others, they are a lot. Mental retardation, epilepsy, substance abuse, suicide, aggression, personality disorders, eating disorders, impulse control. So under the impulse control, so we have a lot. We have the dystonia, the kleptomania, we have the pyromania, we have the gambling. Developmental disorders too are there. We have the autisms, the Asperger's, we have the ADHD, antidiuretic hormone disorders. Then we have the sexual and then the gender identity disorder. So they are a lot. They are a lot. So let's dive much into functional psychosis. Remember, we said under psychosis we have two types. We have the functional psychosis and then we have the organic psychosis. So under the functional psychosis, I'm just talking about the common mental illness, okay? So there are a lot. I can't talk about all of them. There are a lot. So let's pick the common ones. So schizophrenia. Schizophrenia is actually a term which is a combination of two different words, schizo and then phrenia. Schizo and then phrenia, which means that dissociation yourself from the real world. Is that okay? So schizophrenia is a mental disorder which is characterized by disturbance in thought, Yesterday we learned about thought disorders or thought process. Perception, we spoke about perception disorders. We spoke about perception disorders, hallucination, and then illusions. Affect, and then psychomotor activities. So these are the main characteristics of schizophrenia. So in schizophrenia, there will be thought deformation, there will be perception disorders as clinical manifestations. There will be affect changes. So a group of functional psychotic disorders, which is characterized by disordered thinking, that's the thoughts, perception, it's here, and behavior for a period of at least 6 months. Initially, it is 6 months, but then now, even if the patient starts experiencing thought disorders, perception disorders, and change in behavior for even 3 weeks or even 2 weeks, we will diagnose the patient as schizophrenic patient. Now, we don't even wait for that 6 months, the phases to even end. No. The initial phase, no, we will diagnose you. So a group of psychotic disorders of the functional type in which there is disorganization and then so these are all characteristics or signs and symptoms of schizophrenia. So look at here. So there will be what? There will be hallucination. Do you see that? There will be delusion. And then there will be disordered behaviors. So the schizophrenia condition was formerly called dementia precox. That is madness of the young. Initially or formally. As first, they used to call it dementia precox. That is madness of the young. Because it's had been believed that it mostly affects the adolescents as compared to the aged. So they mostly call it the madness of the young. And it was Eugene Blegler who coined the name schizophrenia, which is schizian and then phren. That's a split and then the mind. So your mind is different from how you behave. So let's say how you are behaving, that is not what it is on your mind. So ideally in your mind, you wish to be cool with everyone. But then your behavior won't allow you to be cool with everyone. That's the schizophrenia. So these are 4 cardinal signs of schizophrenia. Is that okay? Cardinal signs of schizophrenia. So we call it. So when Eugene developed or coined the term schizophrenia, he did further search and he identified 4 primary or cardinal symptoms of this schizophrenia. So we normally call it the Bleuler's 4A. The Bleuler's 4A. Is that okay? Those are the cardinal. So if you get a description in your exams and then the patient is experiencing these 4, the main condition that is likely to be diagnosed is schizophrenia. So there will be affect disturbances. Either the patient's mood will be flat, blunt, or incongruent. And then there will be autism. So autism simply means withdrawal from reality. Then there will be fantasies. So autism, you realize that the patient will be withdrawn from reality. So the patient is, let's say, 20-year-old boy, but then he will be behaving like a 6-year-old boy, playing with toys, doing all of these things. That is, and then they like fantasy, they like colorful things. They like enjoyments like they are children. And then daydreaming, that is, they live in their own world. Do you get it? They live in their own world. So that's some of the signs under autism. Then association loosening. Yesterday we looked at thought disorders or thought processes. Association loosening. So by now you should know what an association loosening is. There will be ambivalence. So they'll be expressing contradictory or opposing emotions, attitude, ideas, or desire for a person, object, or situation. So such people, they can argue, papa, they can argue. Even everybody knows that this color is blue. They can argue that no, it's not blue. They know that this color is white. They can argue that no, it's not white, it is black. That's ambivalence, expressing contradictory or opposing what emotions. It affects approximately 1% of the total population. Adolescents and young adults are the most affected age group. Like I said, adolescents, and then that is why initially it was called madness of the young. Causes of schizophrenia. So we have the biological influence, such as genetics. So it's 40% occurs in identical twins, and then 12% in non-identical twins. And then, but this one is so if both parents are schizophrenic patients, is that okay? If both parents are schizophrenic patients, that one, there is 40% chance that the children that they'll be giving birth will have it. That is why in our previous lectures, we were talking about prevention of mental illness. We said premarital counseling. And then if one of the parents is a schizophrenic patient, there is a 12% chance that the child or the one that you will be giving birth would also get it. There is a 12% chance. Then also those that are having the body constituents, yes, they will learn about the body constitution as a factor or a predisposing factor of mental illness. So those that are built or those that are having the body built, the tall and then the narrow, then the long legs, skinny people, they are also at risk. Biologically, they are at risk. And then the pre-morbid personality people, the schizoid personality people, they are also at risk. But then biochemically, excess level of dopamine. You know what dopamine does? Dopamine is a hormone that when released, it will increase your or it will make you excited. It will motivate you. So we have the dopamine pathways, 5 dopamine pathways. Each of the pathways, when dopamine is released, it has the thing that it does in your body system. So dopamine, if there is excess level of dopamine, you'll be super excited, fantasies. And then abnormalities in neurotransmitters such as serotonin. So we have 5 excitement hormones. You can write them down, 5 excitement hormones. We have the endorphins, we have the dopamine, serotonin, we have the adrenaline. So they are then the oxytocin. So they are excitement and relaxing hormones. Dopamine, serotonin, endorphins, dopamine, serotonin, endorphins, adrenaline, and then oxytocin. So they are relaxing and exciting hormones. So if any of these is excessive or excess in you, you jump into schizophrenia stage. You'll be diagnosed with schizophrenia. So it's either your mood, you'll be moody, or you'll be super excited. Causes of schizophrenia, we are still on it. So we have the physiological influence or the physiological causes. We have the viral infection. So sometimes exposure to influenza type A virus during the second trimester. You know, the second trimester, during pregnancy, in the second trimester, which may result in alteration in what we call the hippocampal cells, the hippocampal cells. So if there is viral infection in the second trimester of pregnancy, there is a risk that your child is likely to get some, because we learned in the lecture 2, predisposing factors. We say we have the trilogic model. We learned that we have the agents, right? The agents as a predisposing factor. And we learned of the meningitis, that if a child or a baby is predisposed to meningitis, that child is at risk, or that baby is at risk of getting some mental illness, for that matter, schizophrenia. So influenza type A virus, they causes meningitis. They are one of the causative organisms for meningitis. Is that okay? So if there is what we call the Huntington's disease, disease, if the trauma, like head trauma during birth, alcohol abuse, cerebral tumor, all of those, there will be mixed edema, erythematosis, Parkinsonism, and Wilson's disease. All these conditions, they are predisposing factor of schizophrenia. Then we have the psychological influence, that's poor parent-child relationship. So right from the beginning of childhood, if the child is not relating well with the parents, they will be shouting on the patient, they will be shouting on the child, they will be maltreating the child, and all of those. The child is likely to grow up to dissociate him or herself from reality by not liking any parent or not liking anybody, because he feels like if he get closer to people, they will maltreat him. Then we have environmental factors. So socioeconomical factors too are there. If you've lost your job, if childbirth and then you've lost your child, if there is a divorce and you're heartbroken, and natural disasters, there is fire outbreak and then your home is burnt down, all your properties are burnt down, you are likely to split from reality. So that's it. Then we have general signs and symptoms of schizophrenia. So you can even use the 4 cardinal or the 4 signs to explain it. So we have disordered thoughts, we have disordered emotions, disordered perception. So under the disordered thoughts, we have the association loosening. Is that not it? Under the disordered emotions, it may be blunt, you may be moody. Under the disordered perception, there will be delusions, illusions, there will be hallucinations. Under the disordered movement, there will be dyskinesia, there will be dystonia, and all those. We have disordered volition, we have withdrawal from reality. That's whereby you split from reality. So you can talk about the autism over here. Phases of schizophrenia. So we have the phase 1. We have the phase 1. So that's the schizoid personality. That's phase 1. So in this phase, the individual shows indifference to social relationships. So the person tries to isolate him or herself. The person do not enjoy close relationship. The person prefers to be on their own. So they appear to be cold and aloof. They want to be on their own. If you go to their homes as if they are not at home, but they are there. Even if you knock, they won't mind you. And then the phase 2, that's the prodromal phase. It's also characterized by social withdrawal, impairment in role functioning. So the phase 1, the person will like to be on his or her own. But then if the person has to go to work, the person will go to work. But when he goes to work, he will isolate himself. He doesn't want to talk to anybody. If the person is a father, at the phase 1, he will play the father role. He will give money to the kids. He doesn't want any child to come and tell him good morning. No, he won't mind you. But if he jumps to the phase 2, that's the prodromal phase. That is when the person will start showing the real signs and symptoms. The real signs and symptoms. So all of a sudden, the person will try to withdraw him or herself from the society. He won't go to work again. Even if it's church that is supposed to go, he won't go. You always want to lock up himself in the room. If you greet the person won't mind you. The ideas that the person will be bringing, it's kind of strange. Unusual perception experiences. So this is where the hallucinations, then the illusions, the thought disorders, and then all of those will set in. So at the phase 2, that is where the patient will start showing their real signs and symptoms. And then the phase 3, this is the active phase where psychotic symptoms are prominent. So it is more or less like the phase 2. They are very prominent. And then the phase 4. So the phase 4 too is just the continuation of the active phase. So they experience similar symptoms as those in the active phase. Prognosis for schizophrenia. When we say prognosis, it is the outcome of a disease condition. So for that matter, prognosis for schizophrenia is the outcome of schizophrenia. So return to full premorbid function is not common. So in schizophrenia, before the patient can or the client can return to his normal function as he was, normal person, is not that common. But then several factors have been identified that can contribute to positive prognosis. Positive prognosis simply means that the person won't go into complications. Is that okay? Uh-huh. So there may be only positive prognosis if there is good adjustment, late age of onset in female genders, sudden onset of symptoms precipitated by stressful events, associated mood disturbance, brief duration of active phase symptoms. That's just as or more or less like the prodromal stage. Absence of structural brain damage. So if there is an absence of structural brain damage, then the patient is likely to have a positive prognosis. But if there is a brain damage involved, then that one, the prognosis is likely to be negative or bad. Normal neurologic functioning. So if the patient's or the person's brain functioning is normal, okay, the brain functioning is normal. If you ask the person, give me your telephone number, the person can mention the telephone number to you. Your bank account number, the person can mention, he can recall what happened, the person can recall. That means the person is having a good prognosis or positive prognosis. But then if the patient is or the person is not able to recall even his own telephone number, he is not able to recall, then you should know that the prognosis is really bad. If there is family history of mood disorders and no family history of schizophrenia, then that one, to the prognosis is bad. The prognosis is good. But then if there is a history of schizophrenia, then you should know that such patient is likely to suffer for it for long. So these are some of the positive symptoms. So when we say positive symptoms, they are symptoms that when it's being manifested, it can assist the psychiatric nurse to be able to treat it or to be able to manage it very well. You see, there are some mental illness which presents with negative symptoms. For that one, you wouldn't know the exact thing to treat. But then, if the person is manifesting with positive symptoms like hallucination, okay, the person is hallucinating, so you will surely give the person an anxiolytic or a sedative, which would, enable the patient to sleep or something like that. So that's the difference between positive symptoms and the negative symptoms. So for the negative symptom, when the patient starts experiencing, you wouldn't know the exact symptoms to manage because they are not manifested or they manifest in diverse ways. So you wouldn't know what exactly to treat. Is that okay? So such patient, if the patient is manifesting a negative symptoms, those patients are likely to be in the psychiatric hospital for a very long time, long admission. But then for the positive symptoms, once the patient starts showing positive symptoms, there is a chance that, okay, so the patient is actually recovering. So when you say positive symptoms, they reflect an excess or distortion of normal function and response well towards treatment. So it means the patient is responding well to treatment, like hallucinations, delusions, either persecutory, grandiosity, reference, control or influence, or whatever. Then if there is disorganized thinking or speech. So yesterday someone asked of what echolalia is. It's also a thinking or let me say thought or speech disorder. So echolalia simply means that the person repeats the exact thing that you are saying. Is that okay? So let's say I will ask the patient, what is your name? The patient will tell me, what is your name? Instead of you saying, my name is, what is your name? What is your name? Have you eaten? You also say, have you eaten? Come here. He also say, come here. That's echolalia. Then we spoke about the tangentiality, the circumstantiality, and then incoherence of speech. If there is disorganized behavior like waxy flexibility, when you say waxy flexibility, you see, initially on TikTok, there is this video trending. They will ask, do you know red? Yes. So those people, you see, they can they can stand at one place and then they will be sleeping. Those people who have been taking the so-called red, they will stand at one place and then they will be sleeping. That's waxy flexibility, whereby a person maintain a one position for a very long time. So the person can even squat and be sleeping. That's waxy flexibility. Then the appearance, the person wouldn't look good in appearance. And then inappropriate sexual behaviors. So you look at sexual disorders, the exhibitionism, and then all of those. We will look at them. The transgender. Yesterday, someone was making comparison or was giving an example about mental illness, those in the transgender community, and then those that are in the okay. So yes, there will be agitation. So if there is agitation, then you know the exact symptoms to manage. But then if all the signs that the patient is showing they are negative signs and symptoms, then you should know that there is bad prognosis. Good. So these are the negative symptoms. These are the negatives. So there will be affect flattening. If the person is moody, if the person is moody, if the person's affect is blunt, how are you? Which medication are you going to use to treat such person? Or how are you going to manage, or let's say medically manage that person? So you see, that's negative or symptom. You would even ask the person, have you eaten? The person won't even mind you. What is happening? The person won't mind you. The person even doesn't want to maintain eye contact, doesn't even want to look at you. Allodia, abolition, the person will just be there, not to be the person. Even if you clap, oh, maybe the person has taken medication, you clap for the person, even the person should be happy. Nothing. You can buy him the nicest mansion, nothing. Anhedonia, social isolation. So the person won't even enjoy life. Nothing seems to be excited for this person. Let's look at types of schizophrenia. Types of schizophrenia. So we have the simple schizophrenia. For that one, it starts during the teenage years. So in the teens, it's mostly starting. And the onset is very slow with insidious deterioration of a personality. So the onset is very slow. Some of the clinical so mostly the types of schizophrenia, mostly it's the clinical manifestation, they look alike. Is that okay? But then it's dependent on the particular person behaviors. So mostly we don't diagnose based on the type, like, okay, so this patient is suffering from simple schizophrenia. We say schizophrenia, but if we are managing, we know the type that we are managing. So we have simple schizophrenia. Clinical manifestation, there is a loss of interest in beauty or grooming and moral values. So such person wouldn't even care about his or herself, whether the hair is well groomed, whether the dress is okay or whatever. He shows no concern for criticism from friends and relatives. Whatever you say, the person doesn't mind or the person doesn't care. He may indulge in expensive jokes, shoplifting, armed robbery. Shoplifting, you see that the patient or the person will go to the mall and will just go and steal. He will just go and steal. And then they will just, even the person is rich, the person can afford, let's say, an iPhone. Yes, so he'll go and steal an iPhone. Even though the person is very rich, and then he can afford, let's say, something like a bottle of water. But yes, so he'll go to the mall to go and steal bottle of water, and then they will catch him. So mostly that's the kind of behavior that they put up. Armed robbery. Even what he has, he will even go and steal it. He will go and rob it. Irresponsible life, such as trams, delinquency, prostitution, and all of those. So mostly that's how their lifestyle is. And then they also lack the will of power or drive. They show no interest in school. Nothing motivates them. That's evolution. Nothing motivates them. They don't want to work. They disrespect, and mostly they engage in drug abuse. Mostly they engage themselves in drug abuse. And we have another type, which is, so that's for simple schizophrenia. We have another type, which is disorganized or hebephrenia schizophrenia. So disorganized schizophrenia or hebephrenia. So for that one, the onset, you see, for the simple, the onset or it's mostly affects or starts from the teenage years, right? But then for the disorganized one, it starts in your 20s, mostly in your middle 20s. Is that okay? And it runs a chronic course. It is also progressive. Almost all the mental illness, they are all progressive. Progressive. They start bit by bit. So let's look at some of the clinical features. Sorry, this one is clinical features, okay? Clinical features. Okay. So effect is flat. So no affection, flat. Sometimes it's even blunt. So there will be incoherent speech, that's losing association. There will be facial grimacing and then bizarre mannerism. So they will just be there. All of a sudden, they will just frown their faces. They will just frown their faces. They will just be putting up some inappropriate mannerisms. Visual and auditory hallucinations are also common. Only them, they will be seeing things that no one else is seeing. They will be hearing voices that no one else is hearing. Neologism, they will be the statement that they will be making, they will be mentioning some terms which can't be found in any dictionary. They create their own terms when they are speaking. That's the neologism. Bizarre delusions, rapid decline in self-care. So they don't care about themselves. Whatever they wear, they don't care. Whether they've brushed their teeth or they haven't brushed, they don't care. Whether they've bathed or they haven't bathed, they don't care. Disintegration of personality. This is the most important one. Disintegration of personality. They will try to dissociate themselves. So what they think is different from what they act. And then they will withdraw from the society. Even if you are looking for them, you won't find them. They will be indoor. You go and knock at their door, they won't even mind you. Regression to the point of enuresis and encoprecy. Enuresis, they'll be doing bedwetting. So they'll go and sleep and then they will urinate on the bed. That's enuresis. Encoprecy, they feel like passing through, but they will do it on themselves. They will poo-poo on themselves. That's the encoprecy. They will poo-poo on themselves. They don't even care. They will just do it. Then the enuresis, they will go and sleep. They will just urinate on themselves, just like that. Then we have another type, which is the catatonic schizophrenia. So that one too, it's for the onset, it combines both the onset is just like the combination of the hebephrenia and then the simple schizophrenia, because the onset is sudden and then it affects teenagers between 15 and then 25. For the simple schizophrenia, we said it affects individuals in their teen age, right? And then the hebephrenia, it affects individuals who are in their middle 20s, which is 25 years and above. But then the catatonic one, it affects individuals from 15 years to 25 years. It normally affects them, and it is characterized by marked abnormalities in motor behavior. When we say motor behaviors, how they move about. For instance, let's say how they walk, how they run, let me put this in that way for you to understand it better. And then it is manifested in the form of stupor and excitement. So such patients with catatonic schizophrenia, the patient doesn't walk normally. Ideally, the patients walk like how all of us we've been walking. But then, in a catatonic schizophrenia, the patient there will be stupor. When the patient is walking, it's like the patient is drunk. Then there will be excitement, super excitement to super excitement. Those people, if something small that call for normal excitement, as in you hear smile or laugh, they will smile and shout and be jumping and be just moving everything about, just as if they've won a lottery, as if they've won a lottery. Okay, as if they've won a lottery. Meanwhile, it is a normal thing. So their form of exhibiting excitement is very different. So clinical manifestation, stupor, and then excitement. So they are hyperreactive. Yes, so that's it. Hyperreactive. Something that you will just smile, they will shout and laugh. And then destructive and then violent behavior. Those people, especially if they are excited, you see that if something happened and then they are super excited, if you are standing by them, they can even slap you just because they are happy. Huh. Such people, if they are talking to you and then they are happy, instead of them to just tap you, they can give you a blow just because they are happy. So while we are learning, you'll be relating to some friends that you know, right? Some friends that you know. Someone, if the person is closer to you than the person is happy, he can even give you a blow on your face just because he's excited. And he'll be expecting you to be cheering him up. Then the stupor, motionless, withdrawn, incontinence, refusal of food and drink, waxy flexibility, negativity, and all of those. So extreme psychomotor retardation. That is it. It's like they are drunk. It's like they feel like standing there for a very long time or being in a certain position for a very long time and all of those. So that is it. That's the catatonic. Then we have the paranoid or the paranoidal schizophrenia. The onset is very slow and it's usually in your late 20s or 30s. Such individuals, their thoughts and mood are not seriously disorganized. Is that okay? Their thoughts and mood is not seriously disorganized. They can think very well. If you ask them question, they will answer you. But then there is persecutory delusions. They always think some people are after them. Some people want to kill them. They always feel like some people are already chasing them. Auditory hallucinations. It is only them that they've been hearing things that others are not hearing. Hypochondriasis. For them, always they have serious disease condition, like serious medical conditions. So hypochondriatic patients, for them, they can even come and tell you that I feel like I'm having kidney failure. Meanwhile, the doctor has told them that there's nothing wrong with you, but yes, still no, doctor, no. I feel within me that I don't have kidneys, or let's say I'm having no. They wouldn't say I don't have kidney, but then they will say I have kidney failure. No, doctor, I feel like my heart is not beating. The doctor, oh, everything is okay. No, my heart is not beating. Those people are there. Or that is how the hypochondriasis patients are. Grandiose. They always feel like they are superior. I am the president of Ghana. You can't do me anything. I want to go there. No one can do me anything because I am Jesus Christ. If you like go, you see what they will do to you. There is aggressiveness and hostile. They are not friendly, argumentative. With a little small thing, they will argue with you. Serious arguments. Less disintegration of personality though, but then there is ideas of references and then suspicious of spouse fidelity. So mostly in these women, they always think that their boyfriends are cheating, their husbands are cheating, their partners are cheating. They always believe strongly, they have a suspicious belief of spouse fidelity. That is for the paranoid schizophrenia. So the clinical features, it has been classified or grouped. The residual and then the undifferentiated. Okay, so we have another type 2. So let me talk about the residual and then the undifferentiated. It's basically also a type of schizophrenia. Aside the paranoid, the catatonic, the hebephrenia, the simple schizophrenia, we also have the residual schizophrenia. Just forget about these clinical features. We have residual schizophrenia. It is considered to be a state of partial remission. Patients have experienced or been diagnosed as suffering from schizophrenia at least once, but at moments are not manifesting in the intense psychotic symptoms. So the residual, when you see something is residual, is like a bit. something small. So such people, they've been diagnosed of schizophrenia, but then they exhibit a very little signs and symptoms of it. You see, a very little. So such people, if you don't take care, you may think they are normal people, until you get closer to them. So most of them, they have social withdrawals, and this social withdrawal, it is not more often. Okay, it is not more often. If the schizophrenia sets in, they will just withdraw themselves from society. If they are okay, then now they will come back. Such people, that's how they are. So social withdrawal, poverty of speech or associative loosening, impaired in personality, hygiene, apathy, blunt or inappropriate effects. So just like the other signs and symptoms of the other types of schizophrenia, but then for this one, it's minimal. And then hallucinations and delusions are not clearly what? They are not clearly obvious if present. So like I said, it's very minimal. You have the undifferentiated one. For that one, there is exhibition of psychotic symptoms such as delusion, hallucination, and all of this. But then it cannot be classified under any of those types. Is that okay? So that's the undifferentiated. And we also have the schizoaffective disorders. The schizoaffective disorders. It is also characterized by either depression or elation, as well as psychotic symptoms of schizophrenia. So for that one, there is the presence of depression or elation over or super excited, as well as psychotic symptoms of schizophrenia. So for that one, it talks about all the symptoms of schizophrenia that we've looked at, and then the combination with depression or hyperactive. So for those people, they are mostly hyperactive. And then euphoria. Euphoria simply means that super excited. Grandiosity. You know what grandiosity is. Presence of speech and pressure of speech. So there is incoherence in speech. Sleep disturbances, whether insomnia, and then there will be refusal of food, or they may be depressed, psychomotor retardation. So all the clinical manifestations that we've spoken about under the schizophrenia, together with depression and then hyperactive, you can think of it. Then we have the schizophreniform disorders. The schizophreniform disorders. Patients exhibit clinical features of schizophrenia for more than 1 month, but less than 6 months. And this condition has good prognosis if at least 2 of the following features are present. So if two of these below features are present, so these are the positive signs. If which are present, it means that your client has a good or positive prognosis. So if there is onset of prominent psychotic symptoms within 4 weeks of first noticeable change in usual behavior or functioning. So if there is psychotic symptoms, there is behavior changes or behavioral changes that it is noticeable. That is something that you can see within the first 4 weeks. Then that one, since you can see, you'll be able to manage it. But then if there are signs and symptoms that you cannot see or they are not noticeable, how can you manage it or how can you treat it? Meaning, by the time you realize, it will get out of hand. If there is confusion or perplexity at the height of the psychotic episode, then that one you can notice it and then treat it. If there is good premorbid social and occupational function, then that one you can notice and then will treat it. If there is absence of effect, or maybe if there is absence of blunted or flat effect, then that one you can treat it. Remember, we said what? Flat or blunted effect is a negative. That's a negative sign, which shows that it will be very difficult for your patient to recover, or for your patient to even though it's difficult for you to regain or to restore the patient back to his normal functioning, but then at least you can do something better. But if there is negative signs like blunted or flat effect, that one, the patient has a negative prognosis. So if there is absence of blunted or flat effect, then that one, there is a good prognosis. So this is the end of schizophrenia. So let me pause and then take further questions. So this is all about schizophrenia.